we are supposed to do her per speculum examination before doing the per vaginal examination. On per speculum examination, you rule out if there are any infection, if there is any watery discharge, or if there is any gross bulging of the membrane, gross cervical dilatation. If everything is negative, then we can go ahead and do some test like the litmus test, or the now there are amniotic leakage indicators are available. All these tests we can do. And lastly, we can do per vaginal examination with all sterile precautions for the assessment of the cervical status, or we can do a transvaginal sonography to look at the cervical length. Now, prediction. Okay. So, when we talk about preterm labor, we need to know about if we can predict the preterm labor. So, we have to take a detailed history of any risk factors as we have discussed earlier. Then you advise patient to monitor her uterine activity. Then, as I told you, cervical ultrasonography or cervical length assessment can help us to determine if the woman is at high risk. Ideally, we are supposed to do a transvaginal sonography, and if the cervical length is less than 2.5 centimeters, definitely she is at high risk of preterm labor. A progressively decreasing cervical length on a serial ultrasound will also be an indicator. So suppose if the cervix was around 4 centimeters and now it is progressively decreasing, it has become 3 centimeters, now it has become 2.8 centimeters, that is also a predictor of a preterm labor. Second thing is that bulging membranes can be seen by either coning of the internal os, even if the cervical length is adequate. That is also an indicator that the cervix is weak. Then high levels of salivary estriol can be a predictor, but this cannot be done as a routine screening test, but this can definitely help us in a situation where there is dilemma. So what are the situations where there is dilemma? If a woman has three three or more first trimester abortions and not a single second trimester abortion, then whether you are in doubt whether to put a cervical encerclage knot or not to put a cervical encerclage knot, where we can do these two markers, cervical ultrasonography as against salivary estriol, because putting a cervical encerclage when it is not really indicated will put that woman at high risk because it's a foreign body. So it can be a focus of infection for a ascending infection, and putting a knot may push her into cervical incompetency because of infection and a preterm labor rather than protecting her. So it is a double-edged sword. We have to be really very careful when we decide whether this woman requires a cervical encerclage or she doesn't require a prophylactic cervical encerclage. Then screening for bacterial vaginosis is something which we can do for everyone. And if it is present, we need to treat it with the antibiotics which are safe in pregnancy. Then screening for fetal fibronectin. The fetal fibronectin is secreted by the placenta, and that is also raised if the woman is at high risk of a preterm delivery. Then for fetal fibronectin, we have to collect the swab or a sample from the posterior fornix of the vagina. We can do it in a symptomatic woman between 24 to 36 weeks of gestation with intact membrane, and if the cervical dilatation is less than 3 centimeters. If the cervix is already more than 3 centimeters, we know that it is an established preterm labor. So there is no need to do any predictive test. What are the contraindications? If there are obvious rupture of membranes, there is definitely high level of fetal fibronectin. If there is any vaginal bleeding, the results may be altered. And in cases the cervical surplusage is in situ, a woman may be in preterm labor, but the cervix might not be dilated because the cervix is being held up by the stitch. The relative contraindications are if you use lubrication or disinfectants for cleaning the vagina, and within 24 hours of coitus or after doing the vaginal examination. Now, prevention is, I think, going to be covered later. So, I will thank you all for attending, and I will hand over the next part of the lecture to Dr. Rujul. You know, Rujul is a consultant at SRCC hospital. So, over to you, Rujul.
Our second speaker is Dr. Punit Bhojani. Sir is actually busy in an emergency, so we'll start with the third part of our topic, which is about management of preterm labor. I'll just share the screen. Okay. So Dr. Anagha has told us in detail about the causes and pathophysiology of preterm labor. So just for a short classification as to what are the different types of preterm birth. So the WHO defines as moderate to late preterm as anything between 32 to less than 37 weeks of gestation. Very preterm is 28 to less than 32, and extremely preterm is 28 less than 28 weeks. The CDC describes it as less than 37 as preterm, late preterm is 34 to 36, and less than 34 weeks is early preterm. And we also have the birth weight criteria where we have a low birth weight, very low birth weight, and an extremely low birth weight of less than 2,500, less than 1,500, and less than 1,000 grams. So coming to the management investigations, yes, as a part of management, so CBC and CRP, urine routine, like Dr. Anagha explained, infection is one of the most common causes. So we rule out any urinary tract infection, sending a urine routine and a urine culture. Especially in cases of PPROM, that is preterm premature rupture of membranes, we send a cervicovaginal swab for culture and fetal fibronectin. Ultrasound, now again, like she explained, one to check for the fetal well-being, to check the Lycos status in case of PPROM, the cervical length, and the placental localization. In some cases, we may also need to do the serum electrolytes and glucose levels. This is mainly in case of tocolytic agents, and when we are using tocolysis or magnesium sulfate for a longer time. This I'll explain in detail again. So what are the main aim of management or the goals of management? One is, of course, to prevent preterm onset of labor. Like Dr. Anagha explained, there are certain high-risk factors, especially when you have a multifetal pregnancy or there is a previous history of preterm labor, there is history of cervical incompetence, there is uterine abnormalities. So in those cases, we want to prevent the onset of preterm labor itself. So that would be your primordial or the first level of prevention. In case preterm labor is already started, we want to arrest it if labor is not contraindicated. If preterm labor is already established, we want to have an appropriate management of labor. And finally, we want to now have, once delivered, we need good, effective neonatal care of a preterm neonate. So these would be the main goals of management of preterm labor and preterm birth. So prevention of preterm labor would be primary, secondary, and tertiary. This Dr. Punit will again discuss in detail. Like we discussed in the previous slide, primary would be to reduce the high risk factors. Secondary is when you detect early and you give prophylactic treatment. Tertiary is to reduce the perinatal morbidity and mortality after diagnosis. This again, Dr. Punit would be talking about it, but in prevention, I'm sure he'd mainly talk about a cerclage and the role of hydroxyprogesterone caproate for prevention of preterm. These two are the only two things which have been found scientifically proven to help in prevention of preterm labor. So what are the other measures to reduce preterm labor? Cessation of smoking, treatment of drug abuse, treatment of asymptomatic bacteriuria, maintenance of a normal body mass index, avoiding an interpregnancy interval of less than 6 months, it should, and ideally less than 12 months. Prevention and reduction of multifetal gestation. This is especially with respect to IVF pregnancies. Low dose aspirin. This is not for routine preterm, but this is mainly for iatrogenic, especially with history of previous preeclampsia, is when it reduces the risk of preeclampsia in the further pregnancies and its sequelae. And no single biomarker performs well as a good screening test. It's always a combination. For example, fetal fibronectin along with cervical length, along with previous obstetric history. This would give us a better risk in the current pregnancy. There is no single biomarker or an ultrasound marker which helps as a screening test. So what are the goals of treatment when we want to arrest preterm labor? Basically, we want to delay delivery by at least 48 hours. What is this 48 hours going to help us with? One, it will help us in administering antenatal corticosteroids. It will help us in transferring the mother in utero, means with the baby in utero, to a higher center where we have good NICU facilities, which will be able to take care of the preterm neonate. It can also help in prolonging pregnancy when conditions such as pyelonephritis or abdominal surgery are present but unlikely to cause recurrent preterm labor. And of course, the treatment for preterm labor can be discontinued if either of this. This is mainly pertaining to point number 3. So coming to a very important yet controversial topic is tocolytic agents, especially when used less than 34 weeks. So what are the various options we have? So between 24 to 32 weeks, what is advised is cyclooxygenase inhibitors like indomethacin. After 32 weeks, we do not advise this because of the effect on fetal kidneys. Between 32 to 34 weeks, we have calcium channel blockers like nifedipine and beta-2 agonists like ritodrine and terbutaline. Oxytocin receptor antagonists are also now available. The most common one is etosipan, and the last one is magnesium sulfate. Why did I mention about it as relatively controversial? Because we have a 2009 meta-analysis which shows that tocolysis are superior to placebo in inhibiting contraindications. However, 2012 meta-analysis of 75 RCTs also declared the same. But overall, there was no significant perinatal outcome improvement. So, and there is no statistical reduction in birth in for less than 48 hours with respect when you compare it with magnesium sulfate. So what does this really mean? So in short, ACOG tells us, the American College of Obstetrician and Gynecologists tells us that yes, use tocolysis when you want, one, for the action of corticosteroids, and second, when you have to transfer the mother to a higher center. These are the two most important indications for up to 48 hours. Beyond 48 hours, they've not found to be useful. Rather, now when we come to individual tocolytic agents, it is the side effects which are more disturbing rather than the effect. We have indomethacin, and of course we know it causes reflux, severe gastritis, bleeding. When used after 32 weeks, it can cause oligohydramnios and constriction of the ductus arteriosus. Nifedipine in the mother can cause hypotension, headache, and nausea. Magnesium sulfate, relatively less used as a tocolysis, but it is safe, may cause flushing, perspiration, and muscle weakness. Beta mimetics, again, relatively lesser used now, but they may cause headache, palpitations, hypotension, and hypokalemia. Oxytocin antagonist can cause nausea, vomiting, chest pain, and nitric oxide, again, not very commonly used. So what are the contraindications to any kind of tocolytic therapy? So in maternal, it would be for uncontrolled diabetes mellitus, thyrotoxicosis, severe hypertension, placenta previa abruption. So if you actually go to see, these maternal contraindications are the iatrogenic preterm deliveries, where if the mother has uncontrolled diabetes or is in a thyrotoxic storm or is severe hypertension or with a bleeding placenta previa or placental abnormalities, you'd rather deliver rather than give tocolysis and continue the pregnancy. Or if the preterm labor is so progressed, the dilatation is more than 4 centimeters, that delivery is imminent, there is no point in giving tocolytic therapy, or there is a contraindication to the tocolytic drug itself. Fetal contraindications to tocolytic therapy would be fetal distress, of course, fetal death, any congenital abnormalities which need, again, this is one of the iatrogenic need for preterm delivery, any congenital malformations, and in pregnancies more than 34 weeks. Obstetric causes would include PPROM, which is preterm premature rupture of membranes, chorioamnionitis, in which case, with the infection, you do not give tocolysis. Coming to the next very important part is maternal corticosteroid therapy. So how does maternal corticosteroid therapy help? So we have two drugs, which is betamethasone and dexamethasone. They help in reducing the neonatal risk of respiratory distress syndrome, intraventricular hemorrhage, and necrotizing enterocolitis. A very, very common question asked is, which is better, betamethasone or dexamethasone? Many trials have been conducted which show that eventually both of them do not have a difference. The dose for betamethasone is 12 milligram intramuscular, 24 hours apart, a total of 2 doses. And dexamethasone is 6 milligrams intramuscular every 12 hours for a total of 4 doses. Another one controversial question is in late preterm. So whether to give it after 34 weeks or not. So in many, many centers, 34 to 37 weeks of gestation, again, steroids are not preferred because they may lead to neonatal hypoglycemia, and long-term effect is not seen, especially after 34 weeks. Second point is repeated courses. Suppose you have a patient with preterm labor whom you've been conserving, say, since 26, 27 weeks, and you've already completed one course of corticosteroid. Do we repeat the course? So multiple studies have found that this repeat course is not useful. Rather, what we give is a rescue therapy. Means whenever delivery is imminent, less than 34 weeks, a single dose of corticosteroid would be helpful. What could be the risk of this maternal corticosteroid therapy? The risks of antenatal corticosteroid is premature rupture of membranes. Now, most important is when you have a patient of diabetes or an insulin-dependent diabetes, these steroid injections, they cause a sudden rise in the sugars. Hence, they need to be monitored. You need constant, frequent HGT monitoring to control the sugar. And we need to also tell the patient, make them aware about one condition, like it can lead to decrease in fetal movements for about 12 to 16 hours post the last dose of injection. Next one is magnesium sulfate. We are not talking about magnesium sulfate over here from point of view of tocolysis. We are talking about it from point of view of fetal neuroprotection. Many studies have found that magnesium sulfate, when given in cases of preterm labor, help reduce the overall risk of cerebral palsy in the preterm neonate. This is best seen between 24 to 31 weeks, though most guidelines say that we need to give it from 24 to 33 plus 6 weeks. That is still 34 weeks of gestation. All Indian guidelines give a dose of 4-gram loading followed by 1 gram per hour infusion. However, the Beams trial, which was the original trial, said that we need to give 6 gram followed by 2 gram per hour infusion. So we follow Indian guidelines. Suppose there is no delivery which occurs in the next 12 hours of starting the magnesium sulfate, then we stop the infusion. However, if delivery is imminent, then we resume the infusion. If more than 6 hours of stopping and the labor pains restart, then we have to start again from the loading dose. This we just spoke about. So all this while we were talking about tocolysis and magnesium sulfate less than 34 weeks. What do we do about late preterm between 34 to 37? Again, it is controversial. And the final consensus is that tocolysis should not be used to delay delivery for completion of course of steroids at this gestational age. You should rather give the steroid dose, but no tocolysis. Now, coming to management of preterm labor as labor. So our main goal again would be to prevent birth asphyxia and development of respiratory distress syndrome and to prevent any birth trauma. So in the first stage of labor, the most important point is that the patient is put to bed to prevent early rupture of the membranes. We have need to ensure adequate fetal oxygenation. Epidural analgesia is of choice. Labor should be monitored carefully, preferably with a continuous CTG monitoring. Cesarean delivery. Now coming to mode of delivery, ACOG clearly states that preterm delivery is not an indication for a direct C-section until and unless there is any other maternal or fetal indication, like say hypertension, uncontrolled hypertension, abruption, or a fetal malpresentation. Cephalic presentations can deliver vaginally. A higher risk, however, is seen when you opt for a preterm breech delivery. Another most important point we need to keep in mind is we need to have a good NICU backup. Now, coming to the second stage of labor, the birth should be gentle and slow. So far, we've always learned that episiotomy and use of forceps, prophylactic forceps for preterm is best. However, current studies again are showing that neither may be useful. So we need to decide at that time. Tendency to delay is curtailed. Same, the cord is to be clamped immediately at birth to prevent hypervolemia and hyperbilirubinemia and to shift the baby to the NICU. One more part we need to talk about is intrapartum antimicrobial prophylaxis for perinatal GBS disease. The recommended drug is penicillin and the alternative is ampicillin. If the patient is allergic, then cefazolin, clindamycin or vancomycin can be used. This is a very important table, so which will help us decide, especially with respect to, so we've discussed up to 34 weeks. Between 24 and 34 weeks, we've discussed the management from 34 to 37. And like Dr. Anagha discussed, like the age of viability, the threshold or the watershed level. So what do you do between 22 and 24? This is just a small table to discuss this. So less than 22, neonatal resuscitation, suppose the patient delivers, is usually not recommended. Between 22 and 23, we do consider seeing the rest up to 24 weeks, and at 24 plus weeks, it is recommended. Corticosteroid, again, less than 22 weeks is not recommended. Less than 23 weeks is also not recommended. Between 23 and 24, yes, we do consider, and 24 above, we definitely give. Tocolysis, again, the same as the corticosteroid therapy. Magnesium sulfate is also the same. Antibiotics is at every gestational age to be considered. Why? Because we are giving antibiotics to prevent PPROM and further chorioamnionitis, irrespective of the gestational age, for the maternal indication, not just fetal indication. GBS prophylaxis is not recommended till 23 weeks, after which it is recommended. And cesarean delivery is not recommended till 23 weeks, after which it can be considered. We have a case of acute episode of preterm labor. So we give, this is in just to summarize it. Steroid for patients between 23 to 34 weeks of gestation. If they're receiving progesterone, continue the same regime but do not start the therapy. We can manage it on OPD basis provided the fetal well-being is ensured, and complete bed rest is not recommended. Suppose a patient who's preterm labor, suppose she's had an episode of preterm contraction, say between 27 and 29 weeks, and now they have resolved. So now what do you explain to the patient? One of these are very practical points. One is to avoid any kind of sexual activity. Avoid travel in car, train, or airline. Doesn't significantly increase the risk per se, but otherwise to avoid. We continue the tocolysis, antibiotic prophylaxis, and home uterine monitoring. Neither a benefit nor serious harm of a cervical pessary, though we are not using pessaries in the Indian scenario. Bed rest, hydration, and sedation. Again, there is no convincing evidence for the same. We talk about preterm premature rupture of membranes and its management in short. So what is preterm premature rupture of membranes? Is rupture of membranes before 37 weeks of gestation. It complicates about 3% of pregnancies and contributes to about 1/3 of preterm births. The risk factors can be ascending lower genital tract infection, multiple pregnancy, antepartum hemorrhage, placental abruption, cervical incompetence, and in many times it can be idiopathic. So how is that diagnosed? It's diagnosed with a history of sudden escape of watery amniotic fluid, or you may notice oligohydramnios on the ultrasound. There is pooling of amniotic fluid in the posterior vagina, which we'll notice on speculum examination, where you see the fluid leakage to the internal os. Then we also do the nitrazine test, which turns to blue from yellow, the Fern test, which is seen on a slide, and again an ultrasound suggesting of oligohydramnios. So what are the differential diagnoses? It needs to be differentiated from stress urinary incontinence, profuse normal vaginal discharge, or urinary tract infection causing increased urinary frequency, or a vaginal infection. So correct and prompt diagnosis is imperative for optimum management. The management of preterm labor and PPROM do not per se differentiate a lot. Again, we need antibiotics to prolong latency and improve the perinatal outcome, and corticosteroids to be administered between 24 and 34 weeks of gestation. Suppose PPROM occurs nearer to term, so that is after 34 weeks of gestation, it is preferable to induce labor unless fetal lung maturity or gestation age is doubtful. Thank you, everyone. This is my last slide. If there are any questions, kindly leave them in the chat box. We'll be taking them after this. Our next speaker is Dr. Manju. She is our neonatologist. She'll be talking to you about management of a preterm neonate.
Often.
Good afternoon. I am Dr. Manju. Dr. Rujul very beautifully sketched out the management of preterm labor, and and some management like antenatal steroids and magnesium sulfate, antenatal magnesium sulfate, they extend their benefits to the unborn baby. And it is very difficult to talk about all of the preterm management. It is basically all of a neonatology. So I'll talk just briefly about the WHO recommendations, which they have prioritized some of the questions which are relevant to the parents and to the population as a whole in 2022, and they have recommended some of the management. So we'll discuss about that briefly. Why it is not changing. Just okay. Yeah, are you able to see the slides and hear? Fine. So why we are talking about the preterm birth? If we talk about the magnitude of the problem, there are approximately 15.2 million preterm births worldwide, which are approximately 11% of the live births. And of these births, they contribute to 45% of the babies who die under the age of 5 years. And of these babies, the newborns, 45% of population under 5 mortality are newborns, and of these newborns, 60 to 80% are because of the prematurity and small for gestational age. So such big is the magnitude of this problem. That's why we need to address it separately. And apart from that, it has been observed that this population require the specialized care for their not only for their survival but for their intact survival. So now the focus is shifted just from the survival to the intact survival of the newborn, and we look about the long-term neurodevelopmental aspect also. WHO has previously also given 3 guidelines for the care of preterm newborns, and which was released in 2011. Then some of the aspects were covered in the management of common childhood condition, that was in 2012, and some interventions to improve the preterm birth outcomes in 2015. In 2022, they have released the WHO recommendations for the care of the preterm low birth weight infants, and we will discuss some of these recommendations. Just 1 second, we'll deal with some of the problems here. चलिए, आ सकता है यहाँ से। So, sorry for the interruption. So, just we will briefly talk about how these guidelines were developed. So, there is committee that has been prepared, the evidence synthesis committee, and guideline development committee was from the multiple countries. They have been accumulated, and they identified some of the priority questions and formulated them in the PICO format. And they decided this question in terms of based on the following criteria like values and preference to the families, the public health importance of these questions, availability of the new evidence after the last guidelines have been published, which is of almost more than 5 years old, and questions that has not been addressed by the previous guidelines. These interventions were categorized into three parts like preventive and promotive care, care of complications, and one new aspect has been added, that was the family involvement and the support. And intervention period from birth to 24 months of age was decided, and outcome were classified into the short-term outcomes and long-term outcomes, and the outcome period was considered unrestricted, and various trials and various evidences has been accumulated. They were assessed, and based on that, the guideline development committee gave the recommendations. The target audience for these guidelines are the policymakers, the managers of the health programs, the healthcare facility managers. Apart from that, pediatricians, neonatologists, general medical practitioners, and community health workers. These are all the will be benefited by these recommendations. So just for some technical questions, like what are the, which will come across some terms like strong recommendation. Strong recommendation means that this should be done. The patient should receive this, or this is a strong recommendation. Then the other term which we will come across will be the conditional recommendations, means we can reconsider it as may be considered. This thing may be considered, or this recommendation may be considered. And then there is a good practice statement, means though there is no proper evidence or something, but still by consensus it is a good practice and it should be done. So these are the terms which we will come across. So what are these recommendations that has been given by WHO? We will discuss it one by one. So there are three aspects as we discussed. It is a preventive and promotive care. In this area, they have given 16 recommendations. Then care of complications of the preterm birth, 6 recommendations, and 3 recommendations and 1 good practice statement in the area of the family involvement and the support. So previous guidelines also have addressed all these 3 areas of the preterm infants. So if you see the preterm and promotive care, the cord care has been addressed in the previous guidelines. So nowadays, certain changes have occurred. Cord care means how we are going to manage the cord. This cord management has recently been included in the NRP also, recent NRP guidelines also, whether we want to give the delayed cord clamping, whether the umbilical cord milking should be done. So what should be done at the time of the birth? So nowadays it is recommended that if the baby, even the preterm baby, if they does not require resuscitation, they should be given delayed cord clamping. Umbilical cord milking is not advised as such for the preterm babies, but delayed cord clamping is now recommended. Kangaroo mother care, we will talk in this recommendation. Thermal care, previously it has been discussed that thermal care of the preterm babies are very important, right from the resuscitation room to throughout their stay, transport, everywhere it becomes very important to take care of their temperature and prevent the hypothermia by the plastic wrap in the resuscitation room to the newborn, the warmer and the incubator. These are the part of the thermal care. Apart from that, kangaroo mother care, but it should be taken care of in every aspect of the preterm newborn care. Feeding micronutrients, probiotics, emollients, this all we will discuss in this recommendation. Previously, developmental care, as I talked that apart from intact survival of these preterm newborns are of main focus these days. So developmental care becomes very important. What will lead to the good neurodevelopmental outcome? That is an important question, and various practices has been tried and tested. For some, the evidences are available. For some, the evidences might not be available. So massage, positioning, immunization, and their surveillance or a high risk follow-up, all of these had been addressed in the previous recommendations. If we talk about the care of complications in resuscitation of the preterm newborns, some important care should be taken, like it should be gentle, as Dr. Rujul has talked about. And apart from that, the thermal care becomes very important in preterm resuscitation. Appropriate size mask and ambu bag should be used. Proper gentle resuscitation should be done. And surfactant, if you talk about surfactant is a very important life-saving drug that has saved millions of lives over the years. And if in the recent years it has seen much of a change, right from prophylactic surfactant for the very preterm babies or extreme preterm babies, to now it is considered as a rescue therapy, or it has changed, the protocol has changed from changed to the early surfactant in the babies who develop the signs and symptoms of respiratory distress syndrome, in spite of giving the continuous positive airway pressure. Continuous positive airway pressure we will discuss in this. And oxygen concentration for the resuscitation itself, it is for the preterm newborns, it is different from the term newborns. In the preterm newborns, what we start with is 30% of oxygen as compared to the 21% that we use for the term babies. There could be many complications in the early neonatal period and in the late neonatal period. In early neonatal period, the problems which we mainly tackle is the respiratory distress syndrome, intraventricular hemorrhage, hypoglycemia, metabolic problems, apnea of prematurity. After certain time, sepsis and all, and after certain time, if the baby survives the critical first few days or weeks, after that we might still see the necrotizing enterocolitis, anemia of prematurity, some extrauterine growth retardation, or poor neurodevelopmental outcome. So optimizing the care for improving all these outcomes become very necessary in the care of the preterm. In last few years, we have proper evidence about the family involvement and support, and it has been seen as a very important aspect, and that makes the neonatology very different from the other areas of care where family involvement and support becomes very important, because our population is yet to develop, their brain is undeveloped. And it has been seen that for proper optimal neurodevelopmental outcome, family involvement and support is very important. So this is a completely new area which has not been discussed in the previous WHO guideline. And they have given 3 recommendations and 1 good practice guideline in this area. All the recommendations has been assessed in terms of short-term outcomes and long-term outcomes. Short-term outcomes means mortality, morbidity, and till the time of discharge, whatever problems occurs. And long-term outcomes means mainly the neurodevelopmental outcome or some chronic complications like the bronchopulmonary dysplasia, necrotizing enterocolitis, etc. So we will discuss it one by one. So first is preventive and promotive care. In preventive and promotive care, this first recommendation is about any KMC, that is kangaroo mother care. Kangaroo mother care, as you all know, is defined as the prolonged skin-to-skin contact. And it is recommended in this recommendation that it should be recommended as routine care for all the preterm or low birth weight infants. KMC can be initiated in the healthcare facility or at home and should be given for at least 8 to 24 hours per day. This is a strong recommendation with high certainty and evidence, and there are multiple benefits to the babies, right from the multimodal stimulation, reduced infection, increased quiet sleep, better IQ, earlier growth spurt, some short-term complications has been seen that they decrease, that is with the decreased apnea, decreased oxygen requirement, and overall stability of the newborn. So this is like a wholesome kind of therapy for the baby, and it's very beneficial. So they recommended that where it can be started at home if the baby is delivered at home, or if it is still less than 1.8 kg or 2 kg of the birth and birth weight, then it should be continued at home. And if the baby is at healthcare facility, it should be given at the healthcare facility. Duration at 8 to 24 hours per day is important, as long as, so it is recommended that it should be given as many hours as possible. This 8 to 24 number comes from various trials that they have, which they have used various hours of kangaroo mother care. Some of the trials have managed to give the kangaroo mother care for more than 16 hours per day. So it is not that it is not feasible. It is feasible. Right amount of motivation and staff training is required for that. Very small, like for less than 8 hours is not very much recommended, because if you will give a very interrupted kind of, so by definition, kangaroo mother care itself is a sustained and prolonged skin to skin contact. So it should be prolonged. If it is given for less than 1 hour, then it interrupts the baby's sleep cycle, and it does not give much of a benefit. So it is of importance that the duration should be prolonged. Parents or mother should be motivated for that, and staff should be trained for that. The person who can give the KMC, the mother. Whenever possible, the mother should provide the KMC. That apart from giving the benefits to the baby, it improves the breastfeeding outcome also. So whenever possible, mother should provide the KMC. But sometimes it might be that the mother is not that stable then or available. Then father, other family members can also provide the kangaroo mother care. Then a newer concept came, that is the immediate KMC. So what is the definition of immediate KMC? What is the difference between the regular KMC and immediate KMC? So it has been, and we will discuss that one significant trial India was also a part. Immediate KMC is the kangaroo mother care which is started within 24 hours. So kangaroo mother care for preterm and low birth weight infants should be started as soon as possible after the birth. And it has a strong recommendation with high certainty evidence. This is the randomized control trial that was done in multiple countries, multi-center trial it was, and India was also a part of this, and it concluded that for the infants with a birth weight between 1 to 1.8 kg, those who received the immediate kangaroo mother care had low mortality at 28 days, and those who received conventional care with kangaroo mother care initiated after stabilization. So starting it early becomes very important. So what are the recommendations? It can be started at home if the baby is at home immediately after the birth, as soon as possible. At healthcare facilities, the KMC can be initiated even before the infant is clinically stable. So it is to be stressed upon that for the immediate kangaroo mother care, infant being stable is not that important, mother being stable is important. So if the mother is stable and can give the kangaroo care, that it should be started. We should not wait for the infant to recover from the acute illness until and unless he is requiring the acute intervention for like resuscitation or intubation or in need of the management of the shock or ventilation. But if the baby is already ventilated, stable on that, and is on inotropic support, that should not deter us from starting the kangaroo mother care. It should be started immediately after birth or after initial resuscitation if that is needed. If we talk about where it should be given, as we talked, stable larger infants, KMC should be started in the postnatal ward if the baby is shifted to the mother. If in the smaller babies, KMC should be started in the special care units. There is a newer concept that came as maternal neonatal intensive care units or the couplet care units. In that randomized controlled trials in the centers in India, the maternal and ICUs has also been prepared in the hospitals which were part of it, and KMC was initiated there, and policy of zero separation was maintained. But it requires actually a lot of effort from the institution side and from the setup side, because they cannot be left alone. If we are trying to establish a maternal neonatal and intensive care unit, then there should be a proper monitoring staffs and instruments available both for maternal monitoring and the neonatal monitoring. So there are some issues with establishment of MNICU, but if it gets established, it is very good for the baby. If you talk about the infrastructure, equipments and supplies, it is a very low cost intervention that has a very good long-term outcome. So what we need is a binder, so that the baby can be bound to the mother or the person who is providing the kangaroo care, the warm hat, socks, and a diaper and a nappy. The reclining beds and chairs, if it is available, it will be so that mother can sit for comfortably for long. As we talked about, it should be given for 8 to 24 hours a day as much as possible, and monitoring equipments for the baby. If it is an maternal and ICU couplet care, then monitoring for both the mother and baby should be available. Second recommendation is about the mother's own milk. As we all know, mother's own milk is very best. It is recommended for feeding the preterm and low birth weight infants. Despite many can claims that formula feed is better and baby's growth and everything can be better than the mother's own milk, but mother's own milk is recommended for the feeding of the preterm and low birth weight infants. and including the very low birth weight or less than 32 weeks gestation. Formula milk do not contain the antibodies, though even if they match the calorie quantity and they improve on their protein quantity, but they do not contain the antibodies and immune modulators and primers present in the human milk that protect the immature gastrointestinal tract and protect from sepsis itself. It has been seen that there is consistent evidence of harm from the infant formula on the two critical outcomes that are the necrotizing enterocolitis and infection, and there is a lack of evidence of benefit from the infant formula. Mothers should be encouraged and supported before and after birth to provide their own milk, including the colostrum for their infants. Many a times what happens that because of the baby is preterm and they are shifted to some other hospital, or they are separated from the mother for their management, it becomes difficult for the mother to have the breast milk output, proper breast milk output to feed the baby. So sometimes it might not be available, but still they should be encouraged and supported before and after birth for their providing their milk. So it has been compared in when the various evidences has been evaluated. The formula milk was compared to mother's own milk, and it was found that there is no evidence of benefit of the formula, and evidence of moderate harms in forms of NEC and increased infection has been seen. But still, despite all efforts, if the mother's milk is not available, what is the second choice? So WHO recommends that second choice is the donor human milk. When mother's own milk is not available, donor human milk may be considered for feeding the preterm or low birth weight infants, including the very preterm and very low birth weight infants. And but it has its own problems, like there should be safe and affordable milk banking facilities. When we are saying safe and affordable, it means it should not be very like parents should shell out lots of money for that, or it should not transmit, because ultimately it is a body fluid, so it should not transmit the disease. So you should have a proper milk banking facility which checks for all the diseases that can be transmitted from the milk, and then only it can be used. So it is a tedious process, but still the number of human milk bank have increased very rapidly all over the world, including India. The recommendation is conditional on shared decision making with the parents, and the potential harm of necrotizing enterocolitis from infant formula are more addressed by this donor human milk. Then we come to the aspect, if the preterm baby is on mother's own milk or the donor human milk, still sometimes it is said that their growth is not that appropriate. So it is recommended, whether it is recommended or not, we'll see, multi-component fortification of the human milk. So multi-component fortification of the human milk is not routinely recommended by the WHO for all preterm or low birth weight infants, but it may be considered for very preterm, less than 32 weeks, and very low birth weight, less than 1.5 kg. So there are different kind of opinions for this multi-component fortification. It has been seen that in some of the trials, some of the institutes or trials, 100 multi-component fortification was started when the baby achieved the 100 ml per kg per day. Some started when they achieved the full enteral field, that was typically 150 ml per kg per day. So there was variation when to start and when to start and how long it to continue. But it has been seen that it helps in the growth of the baby, but it is not routinely recommended by WHO. NNF recommendation is that if the baby is not gaining weight on enteral feed of approximately 180 ml per kg per day, then we can try the multi-component fortification. So the remarks which was given by the WHO is commercially available multi-component fortifiers, especially formulated for preterm infants, should be considered, and initiation and duration should be based on the clinical judgment. So it has been seen that there was the variation in the data of the initiation, when it should be started and what should be the duration. It has been left to the clinician. The fortifier is provided in various the evidences. It has been seen that it was either given till the baby achieved 2 kg or till the pre-specified gestational age, like correct gestational age of 36 weeks, or until discharge. So there were variations, but these are the things that various people practiced and published in their papers. Then we come to the next aspect, that is preterm formula. So if none of this is available, no mother's milk, no donor human milk, what we can do? So the next option after the MOM or DHM is the preterm formula. When mother's own milk and donor human milk are not available, nutrient-enriched preterm formula may be considered for very preterm less than 32 weeks gestation or very low birth weight less than 1.5 kg infants. So yes, formula should be considered. This question was previously addressed by WHO in their previous guidelines, but the difference was that from this guideline is that in this guideline, they have recommended preterm formula for less than 32 weeks. Previously, they had recommended that any formula, even the term formula can be, standard formula can be given for the babies. But it has been seen that as the preterm formula is defined as the formula which has energy content more than 72 kilocalorie per 100 ml and protein content of more than 1.7 gram per 100 ml. If the formula is with these specifications, then it is considered as a preterm formula, and it has been seen that the growth is better in very low birth weight and very preterm babies. So guideline development group was not able to recommend a particular type of preterm formula, and there was insufficient evidence to make a recommendation for infants who were born at 32 to 36 weeks gestation. So basically they talk about preterm formula for less than 32 weeks and less than 1.5 kg. And for the group more than 32 weeks, 2 term age or 1.5 to 2.5 kg, they recommend that a standard term formula can be used. So till what time preterm formula should be used? So normally what happens that if we have to mimic what the babies will normally receive. So if a mother delivers a preterm baby, then her milk also has higher amount of protein content and higher amount of energy content. That is called the preterm milk. So mother's transition has been seen that after 1 month of preterm birth, the mother's milk changes from the preterm milk to the term milk. So its composition mimic the term milk at around 1 month of age. So similar thing has been tried that preterm formula can be given for 2 weeks or until they reach the 2 kg. Next recommendation for early initiation of the enteral feeding. So it has been seen, it is recommended that preterm and low birth weight infants, including very preterm and very low birth weight infants, should be fed as early as possible. This is to be stressed upon that they should be fed as early as possible from the first day after the birth. Infants who are able to breastfeed should be put to the breast as soon as possible. Infants who are unable to breastfeed should be given expressed mother's own milk if possible, as soon as it becomes available. But if the mother's milk is not available, it does not mean that baby should be started on the parental nutrition or the IV fluid, but the second choice, the donor human milk or the formula milk, should be started. And they have made the remark that if the human milk is not available, infant can be fed formula, as this is preferable to delayed initiation and enteral feeding and the use of parental nutrition. So it is to be stressed upon. If the mother's own milk is not available, for the fear of NEC, you should not start parental nutrition as soon as possible, but enteral nutrition should be started as soon as possible. There was no difference in the effectiveness by volume of initial feed, so a recommendation was not made, but generally what is being started is 10 to 15 ml of feed on as the minimal enteral nutrition on day 1. Then the other recommendation for the feeding is the responsive or scheduled feeding. So for term, we all know that term babies should be fed on demand. That is the responsive feeding. In healthcare facilities, however, this is also an updated guideline. Previously, WHO had recommended that babies, even the preterm babies, should be fed queue-based feeding, should have the queue-based feeding and feeding fed on demand. If the baby is not getting awake after 3 hours or something, then only they should be fed as fed without any cues. But in this recommendation, they have changed their guidelines rightfully. In healthcare facility, scheduled feeding should be considered rather than responsive feeding for preterm infants born before 34 weeks until the infant is discharged. The harms from responsive feeding. So it is being argued that because of the responsive feeding, initially there is a poor weight gain, and but its benefits are more. There is decreased length of hospital stay, it has been seen, and there is early achievement of the full feeding. Recommendations could not be made for the infants born at or after the 34 weeks of gestation, and they maintain it that they should be. There is no recommendation. There is, because there is no evidence as such. So they maintained that they should be they should be having the Q-based feeding. So the guideline development committee suggests that 2 to 3 hourly scheduled feeding should be used for infants born before 34 weeks of gestation. Responsive feeding requires sensitive and careful observation of baby's behavior. So basically, it is a cue-based feeding. So one should be available to identify the cues of the baby. It cannot be that a person who is caring for multiple newborns can be so attentive to the newborns to identify the cues. So it is difficult to carry out in the healthcare settings. So it is recommended that in healthcare settings, at least healthcare facilities, at least there should be scheduled feeding. And when the baby is discharged to home, the parents can be advised to have the responsive feeding. Then what about how fast the feed should go, or how fast or slow advancement of feeding should be done? In preterm or low birth weight infants, including very preterm, less than 32 weeks gestation, or very low birth weight infants who need to be fed by an alternative feeding method, the volume had to be quantified. So either they will be on gastric tube feeding or the cup feeding. Feeding volume can be increased by up to 30 ml per kg per day. So it has been seen that all trials compared the fast advancement meaning increment of 30 to 40 ml per kg per day, and that was compared with the slow advancement, that was increment of approximately 15 to 25 ml per kg per day. So guideline development group took the conservative value of 30 ml per kg per day. So it has been seen that it does not make much of a difference, and it does not lead to the increased risk of necrotizing enterocolitis if the increment is on the higher side. But there should be careful consideration needed in infants with congenital anomalies and birth asphyxia, because these are the babies who might have gut problems or gut anomalies, or there might be poor gut perfusion that might lead to some problems. So the other question was, what should be the duration of exclusive breastfeeding for the preterm babies? So it is generally what happens that for all the milestones and for their growth, we use the corrected age. So if the baby is born 2 months before or 8 weeks before, we tell that, okay, at 6 months of age, their corrected age is 4 months. So it leads to a confusion that till what time should we start the complementary feeding, and till what time exclusive breastfeeding should be given. So it is recommended that preterm or low birth weight infants should be exclusively breastfed until 6 months of age. Complementary feeding should be started according to their chronological age and not based on their corrected age. So let's summarize what are the feeding guidelines that has been given. So there is not much of a, So there is not much of change that happened except for the few. That is, one was that preterm formula was recommended, and apart from that, not much change in how to initiate the feeding and what should be the smaller the initial volume of the feed, and what should be the modality of feeding, the bolus feed or intermittent feed. On these questions has not been addressed by this recommendation. The other change that was given was from the responsive feeding, as was advised in the earlier recommendation. It has been changed to the scheduled feeding for less than 34 weeks of gestational age infants. Then we'll come to the micronutrient supplements. So one important is the iron supplementation. It has been recommended that enteral iron supplementation should be given for human milk fed preterm or low birth weight infants who are not receiving iron from other source. There is limited data on dose, timing of initiation, and duration of iron supplementation, but based on most of trial which they have used, it suggests that daily dose of approximately 2 to 4 milligram per kg per day of elemental iron should be initiated when enteral feeds are well established and may be continued until the infant receives iron from other sources. If we look into the evidence, it leads to decreased anemia, increased weight and length if they are supplemented with the iron. And the next is the zinc supplementation. It suggests that zinc may be initiated when enteral feeding are well established and may be continued until the infant receives zinc from other sources, like when starting the complementary feeding or from the other nutrient supplementation. Based on most of the trials, it suggests that the dose of 1 to 3 milligram per kg per day of elemental zinc should be given to the newborns, preterm newborns, and it should be initiated when enteral feeds are well established and may be continued until the infant receives zinc from other sources. It has been seen that zinc supplementation decreases the mortality, decreases the respiratory infection, decreases the diarrhea, improve the weight, head length, head circumference, and increased psychomotor developmental scores. And evidence of harm is uncertain. So there are multiple benefits, so it should be given. That is what has been recommended. Vitamin D supplementation is also considered for human milk fed preterm low birth weight infants who are not receiving vitamin D from any other source. And it has been recommended that a daily dose of 400 to 800 international unit may be initiated when enteral feeds are well established and may be continued until the infant receives the vitamin D from other sources. The benefits, if we talk about, it decreases the incidence of bronchopulmonary dysplasia and increase the weight and length of the baby and decrease the neurodevelopmental impairment. The next is the vitamin A supplementation. Enteral vitamin A supplementation may be considered for human milk fed very preterm less than 32 weeks gestation or very low birth weight infants who are not receiving vitamin A from any other source. And there was no trial in less than 32 weeks gestation or less than 1.5 kg birth weight, so no recommendation was made in that area, and it suggests that 1,000 to 5,000 international unit may be initiated when enteral feeding are well established. And if you see about the benefits, there are evidence of small benefits in the area, like decreased mortality, decreased bronchopulmonary dysplasia, pneumothorax, pulmonary hemorrhage, retinopathy of prematurity, patent ductus arteriosus, and periventricular leukomalacia in various evidences that had been reviewed by this committee. For calcium, phosphorus, and maternal multinutrient supplementation, much evidence was not available. So the development committee, guideline development group, they did not make any recommendations. If you compare this with the SPGN 2022 recommendations, calcium, phosphorus recommendation has been done by SPGN, that we routinely supplement for the preterm babies till they attain the term gestational age or till discharge. Calcium by 3 to 5 millimole per kg per day, 2.2 to 3.7 millimole per kg per day of phosphorus. WHO has not made recommendation in this area that we had talked about. 2 to 3 milligram per kg per day of iron is recommended by both. Zinc is also recommended between 2 to 3 milligram per kg per day of dose. Vitamin A is recommended by both. Vitamin A is recommended by both, and vitamin D is also recommended by both the groups. And the next comes the probiotic. It is a area which is upcoming, and it has been very much talked about its multitude of benefits, even for the adults also, but in premature newborns it becomes very important when it is talked about in terms of various benefits. We'll talk about it. Probiotics, WHO recommends that probiotics may be considered for human milk fed very preterm infants, and but it is a conditional recommendation, so it is still maybe considered kind of category, and many trials have been reviewed for this, and different trials have used different kind of probiotics and different kind of organisms, so it becomes very difficult to assess their outcomes. Most trials have used the bifidobacterium species and lactobacillus species, and many trials have used bifidobacterium plus lactobacillus species. And most of the trial initiated supplementation during the first week after birth, typically with the first enteral feed. And in most of the trial, the intervention period was at least 6 weeks, typically lasting until the discharge from the hospital. So from all these trials, the WHO recommends that if we are starting the probiotics, then we can start from the first feed and we can continue till the baby is discharged. But there is not concrete evidence in this area. And if we talk about the benefit, it is After reviewing all these trials, it has been seen that it decreases the mortality, necrotizing enterocolitis, and invasive infections. And there was no evidence of harms that was seen in all these trials. What about the emollients? The application of topical oil is actually our cultural belief that it improves the baby's condition. For the preterm babies, it has been always feared that it will lead to the skin disintegration and it will lead to the infection. And that is why it was sort of a gray area. The WHO has addressed this issue, and it has recommended that application of topical oil to the body of the preterm or low birth weight infants may be considered. So it suggests that sunflower or coconut oil may be used based on what most of the trials have used and showed the benefits. And initiation and duration of use may be based on the clinical judgment, because different trials have different kind of initiation and duration of use. So it is still not a very established or definite protocol when it should be started, when it should be stopped. But the two oils that is recommended is sunflower or coconut oil. The committee also felt that application of oil should be done gently to avoid the skin integrity disruption, and they decided not to make any recommendation on the use of ointment and cream. Why it is so, we will see in this evidence. So if the topical oil versus no topical oil is reviewed, then it is seen that there is decrease in the severe infection, increased weight, and increased length if the topical oil is used versus there is no use. If the ointment is considered topical ointment versus no topical ointment, there is not much of a benefit has been seen. Both of them have not been compared from each other, the topical oil versus cream. So no recommendation is made in that area. So that concludes our preventive and promotive care for the newborns, where feeding, micronutrient supplementation, probiotics, and emollients have been discussed. And apart from that, there is certain recommendation made in the area of complication. So for care of complication, two areas has been covered basically. One is the continuous positive airway pressure, and another one is use of methylxanthine. So you'll see it one by one. CPAP for respiratory distress syndrome. WHO recommends that CPAP therapy is recommended in preterm infants with clinical signs of respiratory distress syndrome. So here it becomes very important. If there is clinical sign of respiratory distress syndrome, CPAP is the first therapy that is recommended. So it suggests that CPAP may be considered as soon as the diagnosis of RDS is made, and that duration should be based on the clinical judgment. It also noted that the evidence on harms, that is the pneumothorax, that is most harm that is being considered when CPAP is started, was of uncertain clinical significance. It also noted that the CPAP implementation must be done with the skilled staff, quality equipment. So it has advised against the use of the handmade equipments or the basic equipments, but the quality equipment should be there, and quality consumables should be used, including the humidified blended oxygen air and monitor should be used. So if we consider any CPAP versus the supplemental oxygen, it has been shown that CPAP is beneficial. It decreases the mortality, decrease the mechanical ventilation, and decrease the failed treatment. If early versus delayed CPAP is to be reviewed, it has shown that there is decrease in the use of mechanical ventilation if CPAP is used early compared to the delayed CPAP. Then the other aspect, this is also a newer concept, the CPAP immediately after the birth. So what happens that in the recent consensus review of the RDS, the European guidelines, they had discussed that CPAP should be given immediately after the birth, even before the assessment for the respiratory distress syndrome. So European consensus recommends that CPAP should be started for all the infants, all the preterm newborns who are less than 30 weeks, even before the assessment of the respiratory distress syndrome, whether they have any signs or symptoms or not. That helps in their airway recruitment, and if it is given, that is called the delivery room CPAP. So if it is given immediately after the birth, then it is quite beneficial for the baby. So WHO recommends that CPAP therapy may be considered immediately after the birth for preterm infants less than 32 weeks gestation with or without respiratory distress. The recommendation is conditional on shared decision making with the parents. So WHO recommends for less than 32 weeks. European consensus recommends for less than 30 weeks of gestation. If we compare the CPAP immediately after the birth versus the supplemental oxygen, it is seen that there is decreased failed treatment if it is given immediately after birth, and there is decreased evidence of the bronchopulmonary dysplasia and pneumothorax. And if it is compared with the mechanical ventilation, then again it is beneficial in the same form like failed treatment, and decreased evidence of BPT is there if CPAP is started early. How the CPAP should be given? So WHO has a specific recommendation in this area for preterm infants who need the CPAP therapy. Bubble CPAP may be considered rather than other pressure sources like the ventilator CPAP. So bubble CPAP is preferred over the ventilator CPAP, but it recommends that nasal interfaces used with the bubble CPAP machine should be carefully selected, and skilled nursing care is needed for the prongs and cannula, so that there is decreased incidence of the nasal injury, which happens with the CPAP therapy. Only commercially available bubble CPAP devices should be used, and locally manufactured or locally made bubble CPAP devices should not be used. The pressure which goes with the locally made device or locally manufactured device is inadvertent, cannot be measured, and there can be variation in the pressure, and that can be detrimental to the baby's health. If we talk about the evidence, bubble CPAP versus other CPAP sources, it is seen that with bubble CPAP, there is decreased incidence of pneumothorax, there is decreased BPD, and decreased failed treatment. So just to summarize, CPAP therapy should be considered for all the babies who have the symptoms of RDS. Definitely before surfactant, CPAP should be given. And for all the babies less than 32 weeks gestation with or without respiratory distress, immediate CPAP should be started. The bubble CPAP is preferred compared to the ventilator CPAP. And these are the previous recommendations that has been given regarding the surfactant and the oxygen therapy of the preterm newborns. And the second area that has been covered in care of complication is the use of methylxanthine for treatments. So first in this area is the methylxanthine for the treatment of apnea. So it recommends that caffeine is recommended for the treatment of apnea in preterm infants. And it noted that the evidence was available for all the preterm infants. So caffeine is recommended for treatment of apnea. So whenever there is apnea, it is used for treatment. The dose which can be used is 20 mg per kg loading dose, followed by 5 mg per kg per day of maintenance dose for 6 weeks. If caffeine is not available, other methylxanthine may be considered. If you see the evidence, methylxanthine treatment versus placebo, it shows that it decreases the death, BPD, mechanical ventilation, and there is improved neurodevelopmental outcome. Then the second use is for extubation. It recommends that caffeine is recommended for the extubation of preterm infants born before 34 weeks of gestation. And it noted that evidence was available only for the babies who are born in less than 34 weeks of gestation, but suggests that caffeine or other methylxanthine may also be considered for extubation of the preterm babies born at or after 34 weeks, also before 37 weeks. For extubation, it can be considered for babies less than 37 weeks. It suggested that starting caffeine 24 hours before a planned extubation, and if the extubation is unplanned, then it should be given within 6 hours and should be continued for at least 6 days. The same dose that is used for treatment of apnea is used for the extubation also. If evidence of moderate benefits has been seen, the same benefits, decreased death, BPD, and decreased failed extubation if it is used for extubation. Then for the prevention of apnea, so one aspect is the preventive management of the apnea. That's when the apnea is not happening, but it is used prophylactically in the babies who are premature. So it has been recommended that it may be considered for the prevention of apnea in infants born before 34 weeks of gestation. It noted that the evidence was available only for the preterm infants before 34 weeks gestation. It can be considered for prevention of apnea after that also, but not much of evidence is available in this area. And if you see the evidence, there is a small to moderate benefit in the form of decreased BPD and decreased apneic episodes. Then the last aspect or last area that is the new area for which the WHO has made recommendation, that is the family involvement and support. So if you talk about the family involvement, recently there are many trials going on in various in many countries for the family involvement in the care of preterm newborns, not only in the at the home or when the baby is with them, but also in the intensive care setup. So WHO has recommended that family involvement in the routine care of the preterm or low birth weight infants in healthcare facilities is recommended. So there are many kind of care approaches, like the family center care approaches or family center approaches has been found to be beneficial in terms of improved neurodevelopmental outcome. So if we discuss in detail, like simple family involvement interventions such as delivery of direct bedside care, if they can be involved in the care of the newborn, and involvement in the medical decision making could be implemented in all settings. It is feasible. Other components that can be considered is to provide the facilities for the relatives to stay near the baby and in the hospital. These strategies which have been implemented, it leads to the reduced length of hospital stay, improve the breastfeeding, and reduce the parental anxiety and stress. It has been seen that it decreases the morbidity in forms of infection, IVH, ROP, bronchopulmonary dysplasia. It improves the weight, length, and increase neurodevelopmental outcome also. Then the second aspect is family support. So apart from immediate family, the family of the preterm and low birth weight infants should be given extra support to care for their infants, starting in healthcare facilities itself from birth and continue during the during the follow-up after the discharge. The support includes the education, counseling. So all the babies who are preterm babies, if the baby is being discharged, the parents should be educated about what can not only the current care, but also what can be expected in the future in the home, and what can be possible complications when they will need to come to the hospital. They should be counseled about the care for the development in the babies, and apart from that, where they can seek the support from the healthcare facility or peer support. All of this includes the education, counseling, and discharge preparation of the parents. So it was noted that the education and counseling also had important effects in improving the parent to infant interaction, improve the breastfeeding, and decreasing the parental anxiety and stress. And support and planning should be started in the antenatal period wherever possible. And it also noted that careful coordination of care is needed post-discharge. The committee decided not to make a recommendation on digital information system because there was very few trials that was available for the digital information system, where the parents have been advised or time to time given the counseling or education regarding the preterm care. So the recommendation in this area has not been made. If we see the evidences that has been available, so if the parents are educated and counseled versus the usual care, it has been seen that there is an increase in the weight, length, and neurodevelopmental outcome. And for all the aspects, all four aspects, it is the same kind of development is available. If the discharge preparation, as I talked about, that what can be expected from the, and when they should, if they clear cut, they told about that this kind of complications can be expected, or if these things happen, or these danger signs are present in the baby, then they should do this, or if this a particular line of management kind of thing is given to them, then there is decreased incidence of the emergency department visits. In the area of the digital information system, as you can see, there is no effect on the emergency hospital visits. So no recommendation has been made in this area. Then comes the last aspect, that is the home visit. Home visits by trained healthcare workers are recommended to support the families to care for their preterm and low birth weight. That sounds very good, but This is not possible in many of the standalone healthcare centers, and for government programs, definitely it will help. And they have already there are many government programs which recommends the home visits and have the personnel for home visits of the preterm and preterm newborns. So trained healthcare workers can include the nurses, midwives, doctors, or community health workers. And it recommends that there should be extra home visits. So preterm newborns not only require the routine visits that are required for all the newborn babies, but they require some extra home visits also in addition to their routine checkups, and for whether they are accepting the feeds well or not, and whether they are growing well or not. And apart from that, the babies who are at high risk of neurodevelopmental impairment, they require the specialized high risk follow-up also. And this committee noted that home visits also increase the exclusive breastfeeding, immunization visits, and parental infant attachment, and decrease parental anxiety. There is evidence that there is a moderate decrease in the mortality, and there is a small decrease in the number of hospitalization if home visits are implemented in various setups. Apart from all this recommendation, that finished all the 25 recommendation that has been made by WHO in the care of the preterm. Apart from that, it has made one good practice statement, that is there is no research or trial in this area, but still it should be done. That is the parental leave and entitlements. Parental leave and entitlement should address the special need of mothers, father, and other primary caregiver of the preterm or low birth weight infant. So it identifies that preterm newborn needs the care, and there should be some caregiver available to the preterm newborn, and that's why this leave and entitlement option should be available to the caregiver. So it considered that parental leave and entitlement should include the additional days of leave from work and additional financial payments. However, there was insufficient information available to enable to make the recommendation. So that's why it is a good practice statement. And it noted that it should be expanded globally across high, middle, and low income countries. And if we see the data that has been given, there are among all the countries in the world, 28 countries had a parental leave policy specifically formulated for families of preterm infants. And it is a matter of proud that India is a part of these 28 countries, as you can see. So, if you see the Maternal Benefit Act 1961, it provides the leave extension in case of pregnancy or delivery complication or premature birth or miscarriage of a woman beyond the recommended period of leave. So that is good, and we should also advocate for the leave benefit and entitlements to the parents for this for the care of the preterm newborn. That concludes the recommendations made by WHO in brief, and there is actually a vast myriad of like management aspects in preterm babies that cannot be covered in this talk, but it is in brief what has been the new evidences and new practices that has been going on in the area of the preterm management. Thank you, everyone. If there is any questions, you can drop in the chat box and I'll try to answer.
Thank you, Dr. Manju, for the informative presentation. And next speaker is Dr. Punit Bhojani. He's a consultant obstetrician gynecologist at SRCC Children's Hospital. And so we'll be talking on prediction and prevention of preterm labor.
Hello. Hello. Yeah, can I have the presentation, please? Yeah, then you can load the presentation. I'll just. Hello. Can all of you hear me? Dr. Rujul, am I audible to all? Am I visible to all? Can you please start my presentation? Yeah, you can go to the next slide, please. Next slide, please. Yeah, thank you very much. Thank you, SRCC Hospital. Yeah, is the all. Am I audible to everybody? Yeah. Am I audible to all?
Doctor. Yes.
Yeah, yes. Yeah. Okay. Yeah. Thank you very much. Thank you, SRCC Hospital. Thank you, Dr. Rujul, for having me here for the program. And it is said that my topic for discussion is prediction and prevention of preterm labor. Next slide, please. A wise man believes in so coming to the introduction. So preterm birth is defined as a birth less than 37 weeks of gestation. It's the most important single-man determinant of adverse outcome in terms of both survival and quality of life, and risk of death or neurosensory disability increases with decreasing age. Next slide, please. The number of risk factors are there for preterm birth, but the most important factor is the history of prior unexplained spontaneous preterm delivery. Next slide. So first part of my talk is about the prediction. Second will be about prevention. So prediction of preterm factors, there are three main factors: maternal characteristics, ultrasound markers, and biochemical markers. Next slide. So when we look at the most important is the obstetric history, always ask on the first history, the previous delivery. And if a patient has a previous preterm delivery, then the risk of recurrence is around 14 to 15%. So such patients, we can do regular screening or progesterone administration, or interventions can be done specific like cessation of smoking, treatment of underlying comorbidities, achieving an ideal BMI can be considered in these patients. Next slide. Yeah, so coming to the cervical length. On ultrasonography, the cervical length is a very important marker for prediction of preterm, and screening by transvaginal sonography should be done in all singleton pregnancies. Threshold for cervical length is considered around 25 millimeters, okay, with a sensitivity of 37.3 and 92% specificity. A recent study has shown that when universal screening is done in the mid-trimester, the woman with a history of, even without a history of preterm birth, there is a reduction in preterm birth. And that is which all our patients we are following, that when we send our patients for a 18 weeks anomaly scan, the doctor should mention about the cervical length. So please make sure that in the anomaly scan report, there is some mention about the cervical length so that we can get an idea. Next slide, please. Cervical length of even less than 15 millimeters considered even more significant, and then there would be 81% specificity and 80% positive predictive value. However, the role of cervical length in multiple pregnancies is slightly controversial. Next slide. So this is how we measure. These are all the picture is showing the cervical length, and this is how the points are there for the cervical length, that it should be a transvaginal approach. Both the anterior and posterior should be properly seen. The bladder should be empty. There should not be any probe pressure, and cervical canal should be visible, and overall the cervix should occupy 75% of the image. So you can see the lower part about the picture of the cervical length. Next slide. Cervicoelastography is a new technique which is not routinely available, but it started coming up in India. And elastography is a condition, is a technique on sonography, where if there's a high elastography index, basically it's going to see how much is the elastic tissue and strain pattern. Then there is a prediction. And it is reported that women had a preterm delivery when lower hardness ratio was there compared to people who did not have. Next slide. Uterocervical angle is again an adjunctive to cervical length. The rationale is that an acute angle acts as a prevention and a mechanical barrier against preterm. There's a correlation that when it's an obtuse angle, 95 to 105, then there's a significant chance of preterm birth. Next slide. So you can see over here that the acute angle of 75 degree versus an obtuse angle of 118 degree. So acute angle is good. Obtuse angle, there's a slightly higher risk of preterm delivery. Next slide. Now coming to the biomarkers. So in biomarkers, there are lots of biomarkers are there: fetal fibronectin, interleukin 6. But in practice, three things: fetal fibronectin, placental alpha macroglobulin 1, and phosphorylated insulin-like growth factor binding protein. These are the most useful available for prediction of preterm birth. Fetal fibronectin is widely used and it has got a good negative predictive value. That means that if it is absent, it is good, the delivery is unlikely to happen. So overall, fetal fibronectin is clinical negative predictive value of 95% in some studies. Next slide. Phosphorylated insulin-like growth factor binding protein 1 is secreted by the decidual cells, and it will leak into the secretions when fetal membranes are detached from the decidua. So it has been used. However, this test is not yet available in India. It is just a very theoretical part that we get this. And similar as one, placental alpha macroglobulin 1 is also a newer marker. Both these markers have a good predictive value, and if used along with cervical length, is a good prediction of preterm labor. Next slide, please. So this is like a summary of what all I have said in prediction. Personal history plays an important role. Clinical presentation important. Ultrasound markers, cervical length is the most important, easy to perform, cost effective. Uterocervical angle, radiologists are not routinely doing it, but we can start incorporating it. And other lots of fluids can be taken, like serum, saliva fluid, cervical canal fluid, amniotic fluid, but these are not commonly done in India, and only fetal fibronectin is probably available, the rest are not available. So there's a limited role. So in summary, when you look at the prediction part, the cervical length is the most important, and the past history of the patient. Next slide, please. Going on to the prevention of preterm labor, the next part. So in next slide, please. So in prevention, one is the cerclage, which in India we are mainly doing only for the second trimester miscarriage of cervical incompetence. Second is the pessary. Pessary, again, we are not using it. So the mainstay for prevention is progesterone. Next slide. So how progesterone works is that progesterone is important in maintaining the uterine quiescence in the later half of pregnancy. And there is evidence that when the labor starts, it is actually going to be the decrease in progesterone which is responsible for initiation of labor. Next slide. So you can see here the various roles of progesterone action in preterm labor. It's a repetition. So next slide, please. On the next slide. So what does progesterone exactly do? It is going to block the prostaglandin F2 alpha and alpha adrenergic receptors, leading to uterine relaxation, decreases oxytocin receptors, increases threshold for stimulation, upregulation of nitric oxide, and blockage or decreased conduction of contraction and suppression of inflammatory cascade. Next slide, please. So progesterone supplementation in women with a history of spontaneous preterm birth. Next slide. So there's a Brazilian trial. Progesterone suppository 100 milligram was given to all the patients, and then the contractions were noted once in a week for 60 minutes between 24 to 34 weeks of gestation. Next slide. So in this, it was found out that there is difference in uterine activity and preterm birth between progesterone versus placebo. More women delivered before 34 weeks in the placebo compared to the progesterone group. And the conclusion was that prophylactic vaginal progesterone reduces the frequency of uterine contraction and preterm delivery in women who are at high risk of prematurity. Next slide. There is a maternal fetal medicine units network trial. This was a double-blind placebo-controlled trial. In this, injection progesterone was used. The previous study was about the suppository. Here 250 milligram 17 hydroxyprogesterone was given. Weekly injections continued till delivery or 36 weeks. Next slide. Next slide, please. Next slide. Yeah, so as you can see over here, that when the injections are given, there is definitely reduction in the number of preterm deliveries. Next slide. So conclusion was that treatment with 17P significantly reduces preterm birth, less risk of NEC, IVH, and supplementation in the NICU, and weekly injections are likely to prevent the recurrent preterm delivery. Next slide, please. Yeah, so another 36, this is one of the big meta-analysis, Cochrane database, 36 randomized control trial, 8,523 women. And for women with a history of spontaneous preterm birth, progesterone is associated with significant reduction in preterm birth before 34 weeks and significant reduction in mortality and morbidity. Next slide. So as you can see, all the meta-analysis favors the role of progesterone for being used in patients when there is a history of preterm delivery. Next slide. So coming to now, when there is a cervical shortening on ultrasonography, what can be done? Next slide. So again, over here, progesterone is helpful. Randomized trial, vaginal progesterone used 200 milligram at night for patients with short cervix, less than 15 millimeters, and progesterone significantly reduced the rate of spontaneous preterm birth before 34 weeks of gestation. Next slide. So as you can see, vaginal progesterone reduces the risk of preterm birth and neonatal mortality and morbidity in a singleton gestation with the mid-trimester cervical length of less than 25 millimeters. Next slide, please. Coming to multiple gestations, next slide, the slightly controversy over here. Because there is the PREDICT trial, 17 centers, Denmark, Australia, twin gestations were randomized to give progesterone pessary versus placebo. Next slide. And what was found was the total of 677 women, incidence of preterm delivery 15% in progesterone versus 18%. So there is reduction, but not statistically significant. So progesterone treatment did not prevent preterm birth. However, there was no harmful effect of infant and maternal progesterone on treatment. Next slide. There is a preterm, this is another study where they compared the progesterone versus pessary versus cerclage. Effectiveness, RCT was done, publications up to 25th January 2016. Next slide, please. So here, there were 23 trials, 6,000 plus ladies, women receiving vaginal progesterones, and vaginal progesterone may be beneficial in twin pregnancy was the conclusion. Next slide. Some special scenarios. Next slide, where there is maintenance tocolysis after arrested preterm labor. It means I have a patient of preterm labor, we gave her tocolytics, labor stopped. Now in these patients also, if I give micronized progesterone 200 milligram daily, maintenance tocolytis, the results are very good, and progesterone can be used as maintenance tocolytic for prolonging pregnancy in case of arrested preterm labor. Next slide. In cases of PPROM, however, there is no evidence that injections, progesterone or pessary could be used, and women with history of preterm birth due to PPROM, when there's a past history of PPROM, they may benefit from progesterone supplementation also. Now coming to vaginal versus intramuscular, what is better? Next slide. So as you can see, vaginal progesterone acts better. There's a uterine first pass. When we use for vaginal suppository, the progesterone is directly going into the uterus and there is migration. So there is much better and also less systemic side effects. Next slide. So you can see that because the progesterone is inserted, vaginal pessaries are used, transportation through the cervix, transportation of progesterone can happen, and there is direct diffusion of progesterone into the uterus via vagina. Next slide, please. So various studies are there. 518 women randomized into either vaginal gel or progesterone injection. Vaginal progesterone better. Adverse effects are more in the intramuscular group, and vaginal progesterone slightly more effective also. Next slide. So coming to certain guidelines to complete my talk, then 2015 FIGO statement that sonographic cervical length measurement should be performed in all pregnant ladies. Vaginal micronized progesterone to be used when the cervix is short. Progesterone formulation could either be gel or capsule. And universal cervical length screening and vaginal progesterone treatment is cost-effective model for prevention of preterm birth. Next slide. Even the ACOG guideline says that in a singleton pregnancy with a past history of spontaneous delivery, progesterone supplementation should be offered starting as early as 16 weeks of gestation, regardless of the cervical length, to reduce the risk of preterm birth. And vaginal progesterone is recommended as a management option in women with a singleton pregnancy without a prior history also, but in a short cervical length if there is detected before 24 weeks of gestation. Next slide. Coming to the SOGC guidelines, if there's a previous singleton pregnancy, level 1 evidence, injection progesterone can be given, and transvaginal route is preferred when the cervical length is lesser. No proven benefits in twins or triplets pregnancy. Next slide. So coming to the conclusion of my talk, prophylactic progesterone administration is an evidence-based method for prevention of preterm birth in women with a previous preterm birth, short cervix, and maintenance tocolysis after arrested preterm labor. Doubtful benefits in multiple gestation. Frankly, we all are using it, but benefit is not proven on clinical trials, and no role in case of PPROM. Next slide, please. Yeah, and the safety of progesterone has been confirmed by numerous trials. Vaginal progesterone is favored over intramuscular injection because of the lower rate of maternal side effects. Next, I think that's the last. Next slide, please. Yeah, thank you very much for your patient hearing. Thank you very much. And I'm sorry, I was supposed to be there physically coming to SRCC, but because I was stuck up in emergency, I had to deliver this lecture via Zoom. Again, thank you, Dr. Rujul. Thank you, SRCC Hospital, for giving me the opportunity. And thank you very much, all of you, for your patient hearing. Yeah. Any questions from the audience, if there is there, or then we can. Dr. Rujul, are you there? Yeah. Okay. Thank you, everybody, for your patient hearing. Thank you.